Hey everybody, welcome back to the ECG of the day. My name is Reed, and don't forget before we get started to download the PDF file for this ECG here, this exact document, so that you can follow along, make your own notes, and use it for your own studies. So let's jump into it. So first thing I like to do is get a grip of what's going on with the rhythm. And I like to call it look at the forest, and the trees of the forest are my QRS complexes, and so I might pick maybe lead 2 or something, and I see I've got this regular complex rhythm. It appears to be wide. If I look up here maybe in lead 1 where this QRS ends on that solid line, you can see it starts maybe right at about 120 milliseconds. So QRS duration, I would say, we'll say borderline wide. And it's pretty regular until we have this beat here. Seems to be an early beat. So we've got an early beat there. Then we have the resumption of our rhythm to the end. It does appear that there are some P waves. So just at first glance, we've got some P waves. And if we want to calculate the rate, maybe I'll find this QRS is on a solid line of just about. So we'll say 300, 150, 100, 75, 60. We've got, this would be 50, so in between 50 and 60, we'll call this 55 beats per minute. And so we would say this is a bradycardia. So we're starting to think of our differentials for bradycardias. It could be sinus bradycardia, you could have an AV block, you could have a junctional rhythm, sinus arrest, all sorts of things. So, but we do see that we have some P waves, and let's evaluate those. We like to say evaluating our P wave atrial activity. Here's our next step. We see that there's P waves that are upright in lead 1. They are upright in AVF, and so the P waves that are conducting to these QRS complexes are going down into the left, which is indicative of sinus P waves. These are sinus P waves. And it seems like that P wave is pretty consistent. Next thing I'm going to do is kind of go through the next aspect of my conduction system, which is my PR interval. My PR interval represents the time it takes for the AV node to conduct that signal down. And if I measure my PR interval, if I find a QRS that starts right on a solid line, let's see if I can find one. Maybe this QRS here, you can see it kind of starts maybe in that 4th line, and you can see maybe just a little bit over 200 milliseconds. I would say my PR interval is probably 220 milliseconds, which is long. So it's a long PR interval. So we've got some type of AV node block, but what type? We'll fill in the type here in a second. So the first thing we need to do to figure out what kind of AV block is it is, does every P wave conduct to a QRS? Well, we see that every QRS has a P wave, P, QRS, P, QRS, but we also need to figure out, are there any Ps that are in the middle of these that don't have a QRS? And so what I want you to notice is that, you might not think that there are P waves that are not conducting, but this early beat that we identified, we should instantly be wondering, did that early beat come from atrial activity? And so I think by actually evaluating this early beat, we might be able to better evaluate our AV node. So let's take a look at this beat. So this beat's an early beat, right? We would expect from our QRS complexes that the next QRS complex would land maybe right there, but this one comes a little early. And so what do we think about this early beat? Was it wide or is it narrow? It does appear to be wide. You can see this complex is wide. So we've got an early beat that is wide. So we like to think, well, is this a premature ventricular contraction or a premature atrial contraction? And what you notice is you got to look in front of it, and you can see that we've got a little kind of bump at the end of that T wave. And that, to me, is really indicative of a P wave or atrial depolarization. And so what you notice here is that we've got some atrial activity. We've got a PR interval that is a little bit longer than our normal PR interval. And then we have this QRS. And so the QRS looks a little bit different, so maybe this actually conducted with what we call a functional bundle branch block. And so what you notice is that, at a baseline, we already have a little bit of aberrancy in our QRS. And so you can see up here in V1, we're starting to kind of get a little out of order, and that's okay. You can see in V1, our wide complex normal rhythm is an RSR prime, which means that we've got late forces going towards the leads that capture the right ventricle, and so we actually, at a baseline, have a right bundle branch block. And then we've got this aberrantly conducted beat, which is, this beat here, all the way up. It still conducts with that right bundle branch block, but it conducts with a little bit more of an aberrancy. And so that aberrancy is more of a negative QRS in lead 2. So likely what's happening here is we're actually getting, we say we have an early P wave. So actually what we're seeing is we're seeing a premature atrial contraction that conducts with a prolonged AV node conduction. So we have an increase PR interval for that beat. And it also conducts with kind of this bifascicular block pattern where not only does it maintain the right bundle branch morphology, so it also conducts with the right bundle branch block, but also it appears that it conducts with maybe a left anterior fascicular block. And I really only say that because you got this really negative lead too. So for that aberrant conduction. So this is really a PAC with aberrancy. And what that means is that when that PAC got to the AV node, it was able to be conducted, but it conducted with not only the baseline right bundle branch block, but the left anterior fascicle has not repolarized by the time it conducted that signal, and so it conducted with a functional left anterior fascicular block. So it's a PAC with aberrancy. And that makes me think that, maybe since there is an early beat there, I wonder if there are other evidence of that. And what you can see is if we look down here at V5, you can see that we've got these atrial P waves after every single QRS complex and T wave. And most of these P waves are blocked. They do not conduct. You can see they all are blocked. Every single one of those is blocked. And so what we're getting here is we're really having 2-to-1 conduction. And so now here's my next question. Is this a second degree block or are these PACs, right? Because by definition, a second degree block is when you have some P waves conducting QRSs, but not all of them. But if you look closely, if I take and draw a line, if I use maybe green, I draw a line from the beginning of this P wave to the beginning of this P wave, and I connect them. And so my test here is to essentially find the exact midpoint here, and we'll draw a line down. And so now we get to see, well, what is going on with this P wave? Is this P wave coming on time? And you can see the likelihood this P wave is probably sitting right there, and I would say that P wave is coming on time. And so in this case, we've got these P waves that are conducting and these P waves that aren't conducting. And so at a baseline, this is what's really interesting. This ECG all through ear has that pattern. We've got this second degree AV block that has 2-to-1 conduction, meaning for every 2 P waves there's a QRS complex. But then here, for this beat, it's a little bit different, where if I measure from P to P, I would expect my next P wave to be here. But in this one, we actually get an early P wave. So this is a PAC, like we said. That's our PAC. Every other P wave that we just discussed that was blocked, interestingly enough, is a normal P wave. And you can see that the shape of the P wave, if you scan through all the leads, is the same. So by definition of that, we would say that this is a second degree AV block, and with 2-to-1 conduction, So really we would call this a high grade second degree block. Right, we can't really call it a type 1 or a type 2 because we don't know if the PR interval is getting longer or shorter or not at baseline. So I hope that all makes sense. Let's evaluate our QRS, right? We're a little behind. Let's get our QRS done. We've got a QRS that is, we said was wide. The QRS axis, well, it's perpendicular in lead 1 and it's positive in AVF. So that means that if it's perpendicular to lead 1, that means that my axis is going straight down towards AVF, which makes sense as positive in AVF. So almost a rightward axis. We already said we had a right bundle branch block, so that helps explain that rightward axis. In the right bundle branch block, it makes sense that what we see these, R prime deflections in V1 and V2, and we also see in the lateral leads, V5 and V6 here, we've got this slurred S wave. That's a slurred S wave, and in the lateral leads, lead 1 and AVL, we've got these slurred S waves that tell us that there are late forces going away from the lateral leads, right? If we have late forces that are having to travel to the right ventricle because that bundle branch is blocked, we're going to get some little slurry S waves in lateral leads. So we've got a right bundle branch block at a baseline. Very nice. Our QT interval seems to be appropriate. If I measure kind of the midway point here in between my two R to R, my T wave ends before then, so I'd say I'm happy with my QT interval. Let's look for pathological Q waves and ST changes. I don't see any pathological Q waves that are really in any anatomical distribution, and I don't see any ST or T wave segment elevations that are incredibly concerning, right? There's going to be some T wave inversions, as you can see with the right bundle branch block. There's always going to be these T wave inversions, T wave changes kind of in the leads that capture that right bundle branch block, which are V1 and V2. And so with all of that, let's put this together, kind of a complex one. So what do we have here? We've got a sinus rhythm. In fact, we have a sinus rhythm with a second degree high grade AV block with 2-to-1 conduction with a ventricular rate of 55 beats per minute. So we've got a bradycardia in that sense. And there also is a premature atrial contraction that conducts with a functional aberrancy with an additional left anterior fascicular block on top of that right bundle branch block. And so just to recap why we get this right bundle branch block plus left anterior fascicular block is, remember guys, these tissues, whenever they depolarize, it takes them time to repolarize. And during that repolarization process, they are refractory. They are unable to fire again. And so if a premature atrial contraction that is coming from somewhere in the atria, if you look at my drawing, if this comes early and it spreads throughout the atria, gets to the AV node, and the AV node sends it down, if one of the fascicles is not completely repolarized, but the rest are, it might conduct with what the pattern would be of a fascicular block. We would call that a functional block. So, hope that helps. This was a bit of a confusing one, guys. If you have any questions, throw them in the comments. If not, we'll see you tomorrow. Have a great day.